Good afternoon, everybody. I'm Dr. Suvadeep. I work in Apollo Hospital. So I feel this is a some crash course kind of thing that for EDIC Part One. When is your exam, by the way? How many students are there? Okay, no. So when is your exam of EDIC One?
8th April, sir.
8th
8.
April.
Yeah.
Okay, so less than a month now at this moment of time.
Yes, sir.
We're having a kind of crash course kind of thing where we'll try to feed a lot of information inside your brain the last 1 month. So a lot of informations will by, but I feel that you must have completed your subject at least once, and everybody is in revision phase of the revision phase of their your preparation. Is that so?
Yes, it is.
Yeah, yes.
Okay. Okay, and everybody is able to see my screen.
Yeah, exactly.
Yes, sir.
Yes, sir, the screen is visible, but please put it in on slideshow mode.
Is this okay?
Perfect.
Okay, thank you. So again, how much is the time is allotted to me, Fatma ji?
So you can take 1 hour.
Okay, no problem. I'll try to finish as early as possible, but I will try to let me. I'll just stop my video. I don't need my video. Okay. So we'll try to cover. It's not possible to cover the entire GI pathologies in the 1 hour period of time, but we'll try to cover the major topics which comes in the questions. We'll try to sail you through with question and answer format, but in the process we'll have a theoretical discussion, and in the theory part we'll try to highlight the I have underlined certain section in the theory portion from where the questions keeps on coming repeatedly. So please be mindful in the entire journey of this next 1 hour. At any point of time, if you have any doubt in the any segment, please do not hesitate to stop me and then ask question. Is that okay?
Yeah, thank you.
So we'll start with a question only. Again, in the EDIC one, nowadays that I think the EDIC one examination has also become sometimes very elaborate. So you might expect a very long questions, and after a very long question, you can expect the actual question which is being presented. Now, the same way that the usually the pictures are not given for the or the images are not given in the EDIC part one examination. Sometimes it might be given as well because the it depends. But today we'll discuss in a broader way. By that time, everybody just go through this case, whatever has been discussed, whatever has been presented. 34-year male, no significant past medical history, presented with 1 day history of severe pain abdomen, radiating to back, nausea, and then non-bilious vomiting, low-grade fever. The labs have been presented. The labs are highlighted, whichever is abnormal. In the exam, you do not expect the abnormal values to be highlighted, but here I have done it for the sake of simplicity so that we do not waste time in this limited time period. So, what is the diagnosis over here? Again, this is not the question, but what do you feel regarding from the entire clinical scenario with the imaging and
Pancreatitis.
with the lab parameters? What is the diagnosis? Acute
Acute
pancreatitis.
pancreatitis.
Good, very good. So it's an acute pancreatitis. The question starts now. So we have identified acute pancreatitis. So what are the identify the true and false statement in the acute pancreatitis? A. Serum amylase is the most sensitive and specific for the diagnosis of pancreatitis. Amylipase is more sensitive and reliable test for the diagnosis of pancreatitis. Covalence and the Gray Turner signs are suggestive of pancreatic necrosis. All patients with pancreatitis needs to be admitted to the ICU irrespective of the etiology and disease severity. And extent of the pancreatic necrosis determines the number of organ involved during the course of illness. So, what do you think? The which all statements are true and which statements are false in the
So A
in
is
A
false,
is false, B is
B is
true.
true, C is
okay,
true, C is also
okay,
true,
okay.
D false, and E is false, we can say.
Good. Everybody goes with the same flow, or anybody differs?
Well, I wasn't sure of C, so I can't, no opinion.
No
Coolings and
opinion about C. No problem. So the answers have been presented over here. So C is actually false. So we'll come to we'll sail through the next of the theory part, and then you will understand the why it is like that. Okay. So again, diagnosis. Two of the following: either lipase is more than 3 times the upper limit of normal with a characteristic pain abdomen, and imaging finding of pancreatitis. Any two of the following fulfills it is a diagnosis of pancreatitis. Regarding the amylase, there are a lot of times the amylase is not very much sensitive. There are a lot of false negative amylase can happen. It might be even normal in 20% patients with an acute pancreatitis. Uh, and in patients with renal failure, the amylase might be artificially elevated or abnormally elevated even without pancreatitis. So it is not very sensitive at specific things. Lipase in a way is more sensitive and more disease specific, and it remains elevated for a longer period of time. Although lipase and amylase are regularly done for the diagnosis of pancreatitis, it doesn't have any relation with the severity, prognosis, and impact on decision to refeed or discharge the patient. So this is one of the very important part, because there sometimes the questions do come that when do you repeat the amylase, whether the amylase or lipase needs to be repeated, whether the decline in the lipase tells you that the pancreatitis is getting resolved or not. The answers to all these questions are no. There is no prognostic value of lipase. The patients with a amylase value of 1,000 units and amylase value of 10,000 may have a very similar clinical spectrum. Sometimes even with the patients the amylase level of 10,000 might have a shorter hospital length of stay, and the amylase level or lipase level of 1,000 might be having a very higher level of hospital stay. So values of amylase lipase doesn't have any meaning. It doesn't tell you what is the exact status or the severity of the disease. You do not require to repeat amylase lipase to document the disease is resoluting or not. So this is one important thing is everybody needs to understand, and the questions do come on that thing. You should not repeat amylase and lipase. Regarding your Cullen's and Great Turner sign, they are not the they do not tell you whether the necrosis is there or not. They are suggestive of retroperitoneal hemorrhage. So the answer C then the previous question was wrong, because the Cullen's and Great Turner signs are suggestive of retroperitoneal hemorrhage, not of pancreatic necrosis. And only 15 to 20% or around 15-30% of patients with the pancreatitis fall into severity of severe pancreatitis, and they only need to stay in the hospital or in the ICU. So otherwise they don't need to stay in the ICU. They can be managed in the ward as well. So any doubt on this? Any doubt in the true false things?
No.
So we everybody has done the good things except that the Cullen's and Great Turner sign. They are signs of retroperitoneal hemorrhage. We'll move on. Regarding the CT scan, again, everybody needs to know why do you need to do a CT scan in the pancreatitis? When do we need to do a CT scan in the pancreatitis? Usually, CT scan of the pancreatitis should be done after 70 to 96 hours or after 3 to 4 days of the onset of symptoms. We should not do a CT scan of the abdomen in the initial days unless your diagnosis is under question. Like suppose you are thinking of pancreatitis, but you might be thinking, okay, this acute abdomen can be because of something else. It might be acute cholecystitis, it can be acute mesenteric ischemia, or any other cause of acute abdomen, because pancreatitis do present with acute abdomen. In that case, you can do a CT scan early. Otherwise, in all proven case of pancreatitis, you should not do a CT scan or MRI of the abdomen within the initial 3 to 4 days. Why it is so? Because the necrosis, whatever happens, or the disease fully gets blown or fully gets manifested only after 3 to 4 days or after 5 days later. So initial, maybe you have done a CT scan in the initial within 24 hours. After 5 days, the CT scan will be entirely different. So it becomes very difficult to make everybody understand, and as a doctor to understand how whether the disease is worsening or not. So CT scan usually try to prefer to delay in most of the patients unless the diagnosis is in a dilemma. And CT scan, but the CT scan is diagnostic in almost 100% of cases. Again, the questions do come because this is one of the most certain way we can say that whether the pancreatitis is present or not. Another
Can I ask a question, sir?
yes, sorry. Tell me.
So how does CT scan compare with abdominal ultrasound in establishing the diagnosis?
So ultrasound is good enough in having a diagnosis because any kind of peripancreatic free fluid collections or pancreatic obliteration you can identify with an EVSG only. The added advantage of ultrasonography is that any kind of biliary, suppose somebody has a gallstone pancreatitis, which is the most common cause of pancreatitis, gallstone and the bile duct stone can be better delineated with ultrasonography only than a CT scan. So ultrasonography becomes a better modality to diagnose a stone in these kinds of patients. So that is why always it is better to have a ultrasonography. In the initial few days of the CT scan, you can defer for the initial 4 to 5 days and you can do it later. Is that okay?
Yeah, thank you, sir.
Okay, thank you. So we're coming to the question number 2. Again, one frequent questions comes under regarding the scoring system and pancreatitis. It is one of the very favorite topic among all the examiners across the world. They will ask in the EDIC 1, they will ask in the EDIC 2, they will ask in your any other. In India, we find it in the favorite topic of the DNB curriculum and all. So scoring system is one thing that everybody needs to be very thorough, especially somebody who ever is reading about pancreatitis or dealing with the patients with the pancreatitis. The questions are in front of you. Again, true and false. All questions are basically true, false, true, false, true, false. You need to identify which are the true statement and which are the false statement. So, A, initial level of amylase lipase on admission correlate with the disease severity. Ranson and Glasgow scoring system are the gold standard to predict severity and mortality, and all other scores are compared with these two for the validation. Apache 2 more than 8 predict disease severity. Balthazar scoring system takes account both extent of pancreatic necrosis and grading of pancreatitis to determine the severity of pancreatitis. Modified Marshall score 2 or more defines organ failure in acute pancreatitis, and persistent organ failure beyond 48 hours indicates severe pancreatitis. What do you think are the true statements over here, and which statements seems to be wrong to you?
So A is false because it's not.
Okay, we have already discussed A is false, so it's
Yeah.
not true. Amylase
B is
lipase
true.
not correlate to the disease severity.
B true, sir.
Okay.
Ransom class. And
V,
Apache is false.
okay.
Balthazar is true, we can say.
Okay.
Marshall modified, I don't know about, sir. This. I
Okay.
think it's.
So again, as I'm saying, everybody needs to be very, very thorough about this scoring system because there are a lot of misconceptions I have found among all the students of whoever is dealing with the patients with the pancreatitis. So it is one of the very favorite topic of the examiners because there are a lot of misconceptions that they are there. So again, let's find out the answers. The Ranson and Glasgow scoring that is a false statement. So it is not a gold standard at all. We'll come to know in soon. Apache 2 is a very good system. So it's one of the it's better than Ranson and Glasgow scale. So coming on the scoring system, the pancreatitis, everybody should know about this Ranson and Glasgow score. Again, everybody should know about the BICEP score. Everybody should not know about the Apache 2 score and the SAP score. So they are so Ranson and the Glasgow and the biceps are the disease specific score, whereas the Apache 2 and the SAP score, they are the physiological score Although Apache 2 and the SAP score are not disease-specific score, but in all clinical trials and all practical scenario, they have been found to better correlate to the disease severity and predict the course of the illness in a better way compared to the Ransom and Glasgow score. Problem of Ramsey and Glasgow score is that first of all, it is very cumbersome to remember in the bedside. You need to always go to the your checkbook or you use a calculator to use it. So practically nobody does in the bedside. How many times I don't know you practice in your setup, but usually most of the time in our setup, we most of the time we do not use Ransom and Glasgow score. So and it is a very high false positive rate. You have to calculate to have a criteria or to calculate the composite score. You need to require 48 hours complete after the admission. Then only you can calculate what is the Ransom score of a particular patient because you need to calculate on admission and at 48 hours of admissions and it doesn't dictate you what will be the treatment directions. Rather than Ranson and Glasgow score, the inflammatory markers based score are preferable in pancreatitis. Like Bishop score is advantageous in this way because it has a component of SARS. Anybody with a so it incorporates the physiological one of the physiological parameters or inflammatory systems in our body, whichever is playing at the time of admission. So you can calculate the Bishop score. Anybody on admission, Bishop score is more than 3, indicates a higher mortality in hospital mortality. So Bishop score has found to be better than any other score than Ramsey and Glasgow. So we do a Bishop score in ours. So everybody needs to know the Bishop score over here. Better scores are still better score as the Apache 2 score and the SAP score because it has been anybody who has an inflammatory SARS response more than 2, they've been found that there is to predict the severity of in a 100% way, but again they are not very specific. But you need to have a inflammatory markers or inflammatory mediators to understand what is the severity of the pancreatitis. Sorry, somebody was telling something. Anybody was telling anything?
No, go ahead, sir.
Yeah, okay, thank you. So, option 3 is not wrong. Ransom and Glasgow are not at all a good scoring systems in the bedside. So they are practically abundant in most of the setting. But you should know what are the components of the Ransom score because each and individual components they have a value. Like somebody who comes to a very high hematocrit and hematocrit falls. So that means that the patient was initially very hemoconcentrated and very much dehydrated. So you need to know that how much fluid you need to be given. And anybody suppose who requires more than 6 liters of fluid in the initial 48 hours in the is a poor prognostic factor as per the Ransom criteria. So you should know that what is the individual parameters of this score, but it is very cumbersome to use in the bedside. Anybody with Apache score at 24 hours more than 8 indicates a disease, indicates a severity of illness. Coming to the Marshall score indicates the organ dysfunction in patients with the pancreatitis. Organ dysfunction is calculated in 3 major domains. One is respiratory, second is renal, and 3 is cardiovascular. So this is the Marshall scoring system over here. So you need to give anybody who has a Marshall score more than 2 in any of the organ is identified as an organ failure. Like anybody's PF ratio due to acute pancreatitis is less than 200 is in respiratory organ failure. So that means that the organ is involved. So severity assessment is done on the basis of the criteria of the modified Marshall score. Who doesn't have any organ involvement, that means it is a mild acute pancreatitis. Who has a transient organ involvement but improves within 48 hours is a moderately severe acute pancreatitis. And where organ failure persists beyond 48 hours, that means it is a severe acute pancreatitis. That is how we do a severity assessment in pancreatitis as per the revised Atlanta classification. So again, everybody should know about this modified Marshall score. And lastly, the Balthaser scoring system or CT severity scoring system. Again, there are a lot of questions comes. What is Balthaser score? What is the CT severity scoring system?
Check the patient in, please.
Yes.
Can we check the patient in?
Hello. Anybody is telling anything? Let me check. Okay. No problem. Should we move? Okay, whoever is not, if anybody doesn't want to ask anything, please keep yourself muted. I would request. So Valtheja scoring system, again, you need to identify. Again, I'm not going through the entire details of the Valtheja scoring system, but CT severity scoring system, everybody should know. Anybody who has a CT severity index more than 7 or more is categorized as a severe pancreatitis. And trust me, a lot of question comes on how you assess the severity of pancreatitis in EDIC exams. Three things you need to remember regarding the outcome of the acute pancreatitis. First, the intensity of the early amplification of the inflammatory response. So, three major determinants of the outcome. First is the intensity of the early amplification of the inflammatory response. That is categorized as on the SARS response. The development and extent of the local necrosis that determines the overall outcome, and secondary infections that happen of the necrosis or secondary infections in the course of the illness, because the infection is the major cause of mortality in all patients with the pancreatitis. There are three major determinants of the outcome: how well you deal the initial inflammatory response, what is the extent of the necrosis, and whether the patients develop secondary infections or not. Going to the question number 3. Is it okay? Coming to the management of the pancreatitis. Everybody's there? So again, you need to identify true and false. What are the true statements and what are the false statements in the question? Question number option A, lactated ringer solution over normal saline should be used for intravenous resuscitation in acute pancreatitis. AP means acute pancreatitis. And fluid sequestration more than 6 liters at 48 hours is a poor prognostic marker of outcome. Epidural analgesia is shown to be effective for pain management in pancreatitis and prevents atelectasis. Patients should be carefully monitored for intra-abdominal hypertension and abdominal compartment syndrome. Prophylactic antimicrobial therapy should be administered to prevent pancreatic infections, surgical interventions, and outcome. An extensive but sterile pancreatic necrosis should undergo debridement routinely. What do you think is the true statements and what are the false statements?
So A is true.
A is true. Okay, very nice.
And
B should be true.
B should be true. Okay.
Yeah. C is
true.
C is also true. Okay.
D false.
D is false.
Okay.
E should be true.
E should be true.
E false.
E false. True.
Yeah. Because sterile, sir, we cannot go for debridement. Sterile pancreatitis. Sterile necrotic.
Good. Very much. Okay. So there are the answers. True, 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 false, false. I think whoever has done in this way, they're the correct one. So we'll just try and understand regarding the management of the pancreatitis in a quick way. Fluid management. Most of the patients require fluid after acute pancreatitis because they're fluid depleted due to vomiting, starvation, SARS response, fluid, third spacing, and everything. So most of the patients do require fluid. You need to give RL is the lactated ringer solutions, or ringer lactate is the preferred solution in pancreatitis, and they have shown to have a mortality outcome benefit. So always any patients come with a pancreatitis, please do use ringer lactate solutions over the normal salines or any other fluid, because in studies it has been proven to have a mortality benefit. But you should give fluid for initial 24-48 hours, but you should always make your fluid under check after initial 24 to 48 hours of administration, because if you keep on giving fluid even beyond 48 hours, that means that either your patients are not doing right or you are not doing right. So either way, it is bad. And anybody who has a positive fluid balance more than 6 liter at 48 hours, that means that it indicates that much of SARS response the patient had and that much of fluid depleted the patient is. And that is always a poor prognostic marker, because the patient, anybody who is third spacing, the fluid keeps on getting accumulated inside the abdomen and that keeps on giving you trouble. So that is a poor prognostic factor. So at least these 3-4 things you should always remember anytime you're managing patients with the pancreatitis. Regarding the pain management, preferred epidural analgesia is the preferred choice of analgesia in all patients with the pancreatitis. it do decrease your requirement of the systemic analgesics, it do decrease your requirement of the systemic opioids. But in case suppose you are not able to put an epidural analgesia, or patient is coagulopathic, or patient is hemodynamically unstable, patient is hypotensive and not able to put an epidural analgesia, then you should use one systemic analgesics either in the form of opioids, the fentanyl, or in the forms of paracetamol. Questions do come whether the morphine is contraindicated or not. Morphine is not contraindicated even in the gallstone pancreatitis. But effective pain control is one of the most important parameter to manage in the initial 48 hours. So that anybody who presents with the pancreatitis, so we have to put them off on either systemic analgesia, systemic continuous infusion of opioid analgesia, or continuous infusion of the epidural analgesia. That has been proven to reduce the 30-day mortality and prevent a lot of pulmonary complications in these patients. Prophylactic and antimicrobials is strict no because again, it first of all it is not required, and second thing, it has shown to increase overall mortality. So we should not use prophylactic and antimicrobials in patients with acute pancreatitis, which seems to be sterile. We should monitor in severe acute pancreatitis. It is one of the indication to monitor intra-abdominal pressure. How do you understand? Anybody is telling anything? Anybody is speaking? Please mute yourself, whoever is not speaking to me. Anyway. Okay. How to understand whether the intra-abdominal pressure is rising or not? Again, the questions do come in both in EDIC 1 and EDIC 2 regarding these things. Anybody suppose on a ventilator, your air pressure goes up suddenly, or your diaphragm is quite elevated. So that means the patient do have raised intra-abdominal pressure. You need to monitor intra-abdominal pressure in this group of patients. Or suppose the patient is becoming progressively hypotensive despite a fluid resuscitation. So they also indicate that the raised intra-abdominal pressure, or somebody who is suddenly your renal function is deteriorating. So that means that your intra-abdominal pressure, probably kidney function is getting deteriorated because of this raised intra-abdominal pressure. So all these things, they do indicate the raised intra-abdominal pressure in acute pancreatitis. So you need to be mindful about those things. Regarding the infection is the pancreatitis, again questions do come. The infection picks everything from which the question might come. I have just underlined it for the sake of simplicity so that everybody can just go through these things. Everybody just remember this part at least. Incidence of infection peaks at 3rd week of acute pancreatitis. We need to usually be careful about the 3rd week. 2nd, 3rd week, we usually be careful. Anybody persistently having unstable and all, we should be very careful about whether they are forming new infections or not. But again, it has been seen almost 1/4 of the patient they develop infection within even 7 days of hospitalization. Earlier the infection occurs, the higher is the mortality. So again, that is true. Suppose somebody comes on day 1 pancreatitis, on day 3 they're becoming septic, and you can document a culture positive. That means that they are the sickest group of patients. What is the potential route? Again, the questions do come over here. The major route of inflammation or infection is the gut translocation, due to either the patient is in ileus, or patient is in a captain indium state, or we are giving a lot of antibiotics which change the antimicrobial flora inside the body. So that is the biggest source of infections in patients with acute pancreatitis. Somebody with cholangitis can develop infections. Somebody with a post-TRCP can develop infections. If they develop hollow viscous perforation, they develop infections. But the commonest source of infection in the majority of the patients is the gut translocation. Everybody should remember that thing. And you should remember that necrosis is a very excellent culture media. So anybody who has a higher amount of the necrosis, probably their risk of infections is higher also as well. So somebody who has just 5-10% of necrosis probably might not develop any infection throughout their course of illness. But somebody who has developed more than 70 or 80% of necrosis is a very good culture media of infection. So they might carry infections easier. So you need to be careful in those group of patients. Indications of the
Can I ask a question, sir?
Yes, please tell me.
So what's the indication for surgical exploration of patients with pancreatitis?
So that is the next. This is the slide. We are here now. What are the
Oh, okay,
indications of
okay,
surgery?
okay.
What is the
All right.
indication of surgery? Again, questions do come on that thing. Everybody should know when do we need to do any kind of surgery in patients with the pancreatitis. First of all, somebody comes with a mild gallstone pancreatitis, we should do a cholecystectomy the same admission, because gallstone pancreatitis has a very notorious tendency to develop recurrent pancreatitis unless it has been treated. So we should do a cholecystectomy at the same admissions. But suppose the gallstone pancreatitis causes severe pancreatitis, in that case we should defer. We should not do a cholecystectomy in the same admission. Probably we should make the patient stable and then send them home, and then maybe we can do a interval cholecystectomy after months. Anybody who has an infected pancreatic necrosis where the percutaneous and other techniques fail to control the infection, then it becomes an indication to do a surgical necrosectomy. Anybody who develops because of the pancreatitis develop severe retroperitoneal hemorrhage, you need to explore. Somebody develops bowel perforation, you need to explore. Somebody develops abdominal compartment syndrome, you need to have a decompression laparotomy. So these are the only few indications of pancreatitis. Otherwise, usually we prefer to avoid surgery in all given setting in acute pancreatitis as per the current dictum. Even the surgery is indicated in patients with the pancreatitis, we prefer to do minimally invasive technique than the open technique. Suppose somebody requires a necrosectomy, it is preferred to do a laparoscopic necrosectomy than an open necrosectomy, because your tissue handling is lesser, your surgical insult is lesser, your surgery related inflammatory response is later, the overall outcome is better. And as much as possible, we try to do percutaneous control of the, or percutaneous putting a drain, to control the infections before taking an actual surgical course. And even the surgery is required, you prefer to delay as long as possible. Usually prefer to have the surgical necrosectomy after 3 to 4 weeks of acute pancreatitis, not immediately. Initial 2 weeks becomes absolute almost no for any kind of surgical interventions as per the current dictum in pancreatitis, unless somebody develops some bowel perforation or somebody developing bleeding inside the abdomen, then you need to explore. There is no other way. But we prefer not to explore within the initial 2 3 weeks of time. We prefer to delay it as much as possible. So I hope this answers your questions, doctor. I don't know where question me.
Yeah, yes, to a large extent. But can I find out now? Supposing the patient has extensive pancreatic necrosis, but it's not infected. Is there any place for exploration also?
If the pancreatic necrosis is not infected, it is sterile, you're pretty sure it is sterile, you should conserve. You should
Okay.
not take any surgical intervention. And it is absolute no. You should not. It increases mortality. There are a lot of papers I have published in the last 10 years. Initial surgical interventions do increase mortality, especially in your if the necrosis is sterile. So we should not do any surgical intervention at all. Irrespective of the whether it is 70% or 80% of the necrosis, you should not do any kind of intervention. Suppose if you feel that your sterile necrosis is becoming infected because patient is spiking fever or something, first of all you should do a percutaneous drainage, try and aspirate the fluid inside from
Fluid.
the abdomen and send it for the culture and document whether it is infected necrosis or not. And then you start them on the broad spectrum antibiotic, and most of the time antibiotics do control the infected necrosis as well. You do not need to open for the even for the infected necrosis. Is that okay?
So how about this? There's a condition they call pancreatic pseudocyst, which I think is a complication of this acute pancreatitis or maybe chronic pancreatitis. What should be the approach, supposing it forms a pseudocyst?
So pancreatic pseudocyst is again the chronic complications, long-standing complications of acute pancreatitis. It usually do happen after 6 weeks of acute development of acute pancreatitis. Suppose somebody has developed pancreatic pseudocyst. Usually we tend to do an endoscopic pancreacystogastrostomy. We put a stent in between the cyst cavity and the stomach so that the cyst gets drained inside the stomach only. So again, it becomes very least minimally invasive and all. So So that is the initial or first line of choice in any
Okay.
patients with the infected pancreatic pseudocyst.
Thank you, sir.
You're welcome. Should we proceed?
Yes.
Yes, sir.
Dr. Chaco is the only person who is talking. Anybody else I can expect
Yes, sir,
anybody. So I'll expect the answers from somebody else as well. So we're going to the question number 4 regarding feeding practice in pancreatitis. Patients should be nil by mouth for initial 72 hours after an acute attack for resting the pancreas to prevent stimuli to exocrine secretion from the pancreas. Okay. Nasojejunal feeding is better compared to nasogastric feed in patients with pancreatitis. Okay, MCT based enteral and parenteral nutrition is theoretically advantageous. Okay, persistence of enteral feeding intolerance usually denotes ongoing local complications like infection, peritonitis, and mesenteric ischemia. Polymeric feeds are cheaper, well tolerated, maintain gas structure and function, and has safe and is as safe as semi-limitable. What do you think is the what are the true and what are the false statements?
A is
So
false.
it
Okay, is false.
is true.
B is true, false.
True. So
Okay,
B is true, sir.
okay. C.
Please,
True.
what's MCT?
Multicenter.
Medical triglyceride.
Okay.
C is true, sir. Actually. Parental
Okay.
advantages.
False.
Both enteral and parenteral.
That's true, sir.
Okay. D. What do you think about D?
True.
True, sir.
True.
And it's false, sir. Actually, not cause infection.
Okay.
And C is true also, sir.
B is true, false. Anybody wants to differ? Sorry. Anybody wants to differ? Or everybody is
You're not too sure.
united?
Yeah.
So revealing the answer.
Elemental feed, na, sir. I think it's semi-elemental. So I think it's.
So the answers are already in the board.
Yeah.
So we'll come to the explanation part with some amount of things. Okay, you will remember. Feeding practice in pancreatitis. First, there is no concept of pancreatic rest. So we should start enteral nutrition as early as possible, immediately after hemodynamic stabilization. Somebody who is on triple inotropes, we usually prefer not to start feeding at that point of time. But suppose somebody is otherwise stable enough, we usually start feed as early as possible in all cases of acute pancreatitis. But it is important to remember we need to start in a very small amount. First day we usually start to 50 to 500 ml a day. Just to see, there are a few patients where this kind of feed, small feed, promote vomiting, ileus, pain abdomen. That means that he is not tolerating. You need to stop. So we need to monitor for the tolerance. Somebody is tolerating, you gradually increase over the next few days. So that is what is the discount. So feeding needs to be started early and gradually increased over the next few days. We should not start feeding as a full feed on the day one because that increases the chance of pancreatic ischemia. So we should not do that. So that is one thing that we should always remember. Start feeding early, but not at a full feed in the initial days. Start feeding at a lower amount and then gradually increase over the next few days. There is no difference between the NG and the NJ feeding. It has been proven that the NG feeding is cheaper, easier, quicker. You can initiate the feeding quick in a earlier. If you need to wait for the NJ, first of all, putting an NJ is a little cumbersome. It requires expertise, it requires some amount of CM, or it requires some amount of endoscopic intervention. So it delays the initiation of the feeding. And there is no theoretical benefit over the NJ versus NG. anybody who is not tolerating NG feed, like suppose developing gastroparesis, or suppose somebody is developing pyloric obstruction, in those patients we need to have a post pyloric feeding in the form of NG. Otherwise, you should always start on NG. There is no difference in outcome in NG versus NJ. Should always remember that, because the questions MCQ do come on this aspect. Whenever enteral feeding is not been tolerated even after 5 to 6 days, 7 days of trial, we may consider giving a TP. We may consider giving a parenteral nutrition, but parenteral, in all patients, the parenteral nutrition should be combined with the enteral nutrition as much as possible, as far as possible. Enteral is always preferable. There is no benefit over the semi-elemental feed over the polymeric feed. So all practical purpose, we should use the standard polymeric feed than a semi-elemental feed. MCT based feed do have some theoretical advantage over the LCT based feed. Why? Because it bypasses the requirement of the pancreatic exocrine function for absorption. So for all kinds of long chain triglycerides, they require to be broken down to short chain fatty acids and MCTs by the pancreatic lipases. For the MCT, you do not require that kind of any function. It can directly get absorbed in the portal system and get circulated inside the body, and it gets a complete it has a complete mitochondrial oxidation. So risk of hypertriglyceridemia is much less than in the MCT. And whoever is on parenteral feed, we should monitor triglyceride at least twice weekly whenever we are starting a lipid-based feed in patients with the pancreatitis. Lipid-based feed are not contraindicated, but if we're starting, we should monitor triglycerides in all patients. So I hope it answered all the questions over here as well.
Sir, sorry, actually, sir, the enteral and TPN. So when we start enteral, when we start TPN, sir, sorry, little bit more clearance. I just missed this.
So enteral feeds needs to be started as early as possible within the preferably immediately after the some amount of initial 24 hours. Your initial resuscitation part is over. Comes to the severe pancreatitis, you should start enteral nutrition as much as possible. Suppose
Okay,
with otherwise stable, you can start oral feeding within 24 hours period of time. As soon as your pain control is adequate, your resuscitation phase is over, then you can start the enteral nutrition. Start enteral nutrition in a slow way. Like, do not give a 2 liter of feed in a day. Start with just 200 to 50 ml of feed in a day. Like, then it's a kind of more trophic feed you need to start as early as possible.
TPN, sir, when to start TPN?
TPN, again, we prefer to avoid TPN in all practical purpose. We prefer to avoid TPN, total parenteral nutrition. Suppose somebody has a hollow viscous perforation, developed complications like retroperitoneal hemorrhage, where patient remains in ILS for a long standing, more than 7 days, 8 days, 10 days, then you should consider starting TPN.
Okay, sir.
Okay.
Right.
What is the question? When MAP is less than 65 for more than 24 hours span feeding. Okay. Should we proceed?
Yes, sir.
Yes, let's go ahead.
Yeah, let's go ahead. Let's move ahead from pancreatitis. So we'll talk about some diarrhea. So diarrhea is in ICU is a common problem. What are the true and false statement? How much time is left? I don't think I'll be able to complete. In that case, I will take another class. Diarrhea in ICU. So again, all the options are given. So you need to tell that what is true, what is the false statement over here. Patients with diarrhea have a high DCC rate across the admission. Longer length of ICU stay and itself is an independent risk factor for adverse outcome. Enteral nutrition should be drawn if there is a diarrhea in the patients undergoing NG feeding. Loperamide should be used early to prevent fluid and electrolyte loss in case of diarrhea in ICU. Cholestyramine should be used. Loperamide should be used severe diarrhea. What do you think is the true statements and the false statement? No answer.
A is false.
Okay, A is false.
A is true, sir.
Okay, A is true. Okay.
B.
B false.
Okay.
C false.
Yeah, C false. D true.
Okay.
E
And
true.
yeah, D. Uh,
E should be true.
E true. Yeah, could be. Because loperamide after and LS2.
Everybody okay with the same answer? Mir, Irfan, Sajid, Venkata, Victor. Are you there, guys? Altaf.
Yes.
Everybody agreed with the answers provided by uh, Mr. Chaku and Mr. Mir. Like, I don't know who has given the answers. Mahi. Okay, let's not find out. So the answers have been put in the screen. Can you see? So A is false, B is false, C is false, D and E is are true. So we'll talk about briefly about diarrhea and issue again. Why I have selected these topics because most of the time they're the very small topics. We keep on neglecting these topics, but they're very common topics. They keep on coming in the exam. They keep on coming in the practical management of the patient. So we should all know about it, and we should all know everything about all those things to be very frank. Diarrhea in the ICU is again very common phenomena in the ICU, isn't it?
Yeah.
What do you think, Dr. Chaco? It's very common
Yes,
in
sir.
our ICU.
Yes.
Yes. So certain things we need to remember. Uh, First of all, diarrhea in ICU it indicates the disease severity, but again, it's not it itself by itself is not an independent risk factor for adverse outcome.
Yeah.
So again, this questions has been taken from somewhere, so there is no other reference about from it. Just remember that the statement is like that only. Second thing is that but more important thing is that whenever there is some diarrhea, we should not stop RT feed immediately, but we should avoid hyperosmolar formula feed in those patients. We should use feeds which is isosmolar or semi-osmolar, isosmolar feeds. Regarding the treatment of the diarrhea, most of the time the patients remain on some prokinetic agents, stool softeners, or laxative. We should stop those things because they become the predominant cause of diarrhea in patients. Cholestyramine can be used in bile acid malabsorption, like somebody with a short bowel syndrome or terminal ileal resection having diarrhea. We might give cholestyramine in those patients because uh, they can develop bile acid malabsorption diarrhea. Somebody who has a ileostomy, a very high ileostomy output, you can use loperamide. Otherwise, loperamide is preferably avoided in patients with the infective diarrhea, patients with a diarrhea associated with ulcerative colitis, patients associated with C. diff diarrhea, or patients with an antibiotic associated diarrhea with colitis. So those patients, loperamide is preferably to avoided. It can be given only in selective cases like somebody with a severe diarrhea with ileostomy. You can give loperamide because it acts on the small bowel and then it decreases the output of the secretions from the bowel GI tract. This is the kind of very symptomatic treatment chart treatment algorithm everybody should remember. What is the management algorithm? Somebody who comes who is having diarrhea in the ICU. So everybody should go through this algorithm, and I hope everybody, whoever is working in the ICU, their ICU has their own protocol to manage patients whenever the diarrhea happens. So we should use those kinds of algorithmic approach to control the diarrhea in any particular patients. So this algorithm is was given by the this is given by the ESICM and been published in the reference text. So we can use this kind of algorithm to manage the diarrhea. Coming to the question number 6 regarding Clostridium difficile infection. A. C. diff is an anaerobic toxin producing gram-positive spore-forming bacterium. This bacteria predominantly proliferates in the small intestine and appendix. Presence of pseudomembranes in proctoscopy and colonoscopy reliably diagnose C. diff infections where laboratory assay is negative. Toxic mongacolon can happen in case of fulminant colitis from C. diff infections. A negative Clostridium difficile toxin at the end of 14 days is a test of cure in patients who are medically treated. So again, come on, please answers fast. True
So
first, true
A
first.
is true.
Is
Yeah.
true. Good.
Mhm.
B is false.
Gram positive or gram negative bacteria?
Is a large
Positive.
boil.
Hmm?
Positive.
Okay.
B is false.
B is
C
false.
is
Why does it
true.
proliferate in that case?
Large intestine.
Appendix.
So that is given over there, small intestine and appendix. Do you think it is right or it is wrong?
Wrong.
So it is wrong.
It should
False.
be colon.
Huh?
False, sir.
It proliferates in large intestine.
Okay.
Then
Good.
C is true, sir.
Okay.
D is true.
Very good.
And E is
Also true.
true. True.
E is also true. So which one is wrong?
So B is wrong.
B.
Everybody agrees to that? Somebody has put something in chat. Sajid says it is. Sajid, are you talking about the same questions or what do you think? Sajid is telling it is F2 F. Okay, let's see the answer. So
True.
this is the answer. So please do remember these things, and then I'll just proceed to the C. diff infection, because C. diff is one infection, or C. diff is one topic which is very dear to the examiner's heart and dear to the EDIC question setter's heart. So you might expect a questions from C. diff infections, because it is one of the registered organism. Every intensivist should know about it. So we should all know about it. We'll have some theoretical discussion of C. diff infection, gram-positive spore-forming bacteria. So everybody was right about it. It grows mainly in the large intestine. Again, everybody was right about it. So it do grow on the colon only, or large intestine only. It doesn't grow in the. It doesn't stay in the small intestine that much. Clinical manifestation, again, everybody should know that what is the severity classifications of C. diff infection, mild, moderate, severe. When it is severe C. diff infections, when we call it as a fulminant colitis, because the treatment do differ on the basis of the clinical manifestations. Diagnosis usually is a two-step approach. First, we screen with GDH, which detects the antigen, or we screen a SNAT test, which detect the strain itself. And after detecting the antigen or detecting the screening this, we perform the toxic analysis of the toxin and toxin B with enzyme immunoassay. And because there are a lot of non-toxigenic strain of C. diff is there in the colon, which do not cause diarrhea. So suppose somebody is GDS positive and EIA, Indian immunoassay toxin is negative, that means that the probability is a non-toxigenic strain. They do not require any treatment for the C. diff. So that is why it is a two-step approach. And uh, third, there are some institutions which do a PCR test as well. Most of the centers, like we, do not do any PCR testing for C. diff. Where all these tests are negative, but despite there is a strong suspicion, we can do a endoscopy, a lower GI endoscopy, and we can actually document the pseudomembranes in the colon, which becomes a confirmatory test of the C. diff infections. So for C. diff infection, treatment for mild to moderate, metronidazole is the treatment of choice, or vancomycin is the treatment of choice. We should remember it is the oral vancomycin that we need to give, and the dose is 125 milligram QID. We cannot give 500 milligram OD. That doesn't work. The frequency of the dose is most important over here. The interval of the dosing interval is the most important over here, because it acts luminally from inside the lumen. It doesn't act systemically. So oral vancomycins can be given. In resistant cases, we can give pyroxamine, which is available nowadays. And in very recurrent cases, there is some new monoclonal antibody has come, which is called bezilotuximab, which are been tried in various resistant cases. Please do remember the name of all the medications and all. Surgery is indicated when there is some severe fulminant colitis developing toxic megacolon kind of thing. The patient might require subtotal colectomy in those patients. And in recurrent cases or resistant cases, fecal transplantation sometimes are required. But most importantly, the test of cure is not required. Somebody who have started C. diff infections, the diarrhea settled, you do not require to do another C. diff toxin test to document the C. diff has been cured or not, because toxins do stay positive for a longer period of time, as long as 30 months, 30 days. It doesn't mean that you need to continue the duration of treatment beyond 2 weeks. So test of cure is not required for anybody who has been medically cured for after the end of the treatment. So that is why the questions come. So I think that tells you that the last
What is the test of cure, sir? Sorry, sir. What is the test of cure?
cure
Sorry.
means at the end of the day you do another toxin analysis and then you try to prove whether the C. diff has been cured or not. You should not do that. You don't need to do that to prove that your C. diff has been treated.
Okay, sir.
Okay. Small talk about the toxic megacolon, because they might get questions from the toxic megacolon. It's a non-obstructive colonic dilatation of the with features of the systemic toxicity. So there's specific diagnostic criteria where your colon size on the X-ray or CT scan is more than 6 centimeter, along with signs of systemic toxicity with this diagnostic criteria. And we need to identify and treat it quickly. So I'm not going into again the theoretical discussion, but you should know something about the toxic megacolon, what the cause, what the treatment, how to identify those things. The predominant cause of toxic megacolon is C. diff, inflammatory bowel disease like ulcerative colitis, and CMV infections in ICU. Question number 6 is question number 6 or 7. Okay. 83-year-old female, history of colonic tumor, admitted with abdominal pain and absence of flatulence. CT scan, colonic diameter is 8 centimeter, small bowel diameter is 4 centimeter. So what do you think? They've given you the X-ray picture of abdomen. What do you think? This patient is small bowel obstruction, large bowel obstruction? It should be easy. Anyway, everybody.
Large bowel obstruction.
Large bowel obstruction, sure, not small bowel obstruction.
Large bowel obstruction.
Fine, everybody.
Small bowel, sir.
Small bowel. Large
Because
bowel.
colonic diameter and no air in the rectum.
When do you think that there is a bowel obstruction? What is the any cutoff diameter? Do you know? Okay, the answer is over here is large bowel. As you have rightly said, it is large bowel obstruction only,
Okay.
because here the colon is dilated and the small bowel there is some dilation is there, but again it is less. Coming to the question number 7. Question number 7 is regarding Ogilvie's syndrome. I hope everybody has heard the name of Ogilvie's syndrome. Again, true and false. It is diagnosed when there is a mechanical large bowel obstruction causing a colonic diameter more than 6 centimeter. It can lead to abdominal compartment syndrome. Cecal diameter more than 12 centimeters is a risk factor for perforation. Neostichment is a standard pharmacological treatment for acute colonic pseudo obstruction. Surgery should be contemplated if endoscopic. So, what do you think? What are the true or the false?
I don't even know what Ogilvie syndrome is.
So A is true.
A is true. Okay.
Mechanical causing colonic.
What do you think about B?
B is also true, sir.
A is false. B is true.
Okay.
C is
And
true.
true, yes.
True.
D is also true.
True.
B is true.
This is false.
B is false.
True, sir. In neurosegment, I think.
Okay.
E is
Good.
false. E is false.
E is false.
False.
False. Anybody wants to change the stance? Okay, let's see the answers. Answers on the screen. A is false except everything they are true. Okay, we'll learn briefly about Ogilvie syndrome, because again it's one of the favorite topic of the EDIC examiners. Before that, what is the diameter threshold for dilatation? Calling it as a bowel dilation. For small bowel, cutoff is 3 centimeter. For colon, the cutoff is 6. Cecum cutoff is 9. Just remember, because sometimes they do give a value and then ask questions about that thing. Just to easy to remember and nothing more than that. So Agilvi syndrome is acute colonic fluid obstruction. It's a dilation of the colon in absence of any mechanical obstruction in any severely ill patient. So if there is some mechanical obstruction, like there is a tumor inside the body, in large bowel tumor which is causing large bowel obstruction, like in the last questions that we have discussed. So that is not Agilvi syndrome because there is some mechanical obstruction causing large bowel obstruction. So in absence of any mechanical obstruction, suppose the colon is dilated and colonic diameter is more than 6 centimeter, then it is called Ogilvy syndrome. It's mainly caused by in the old age with the critically ill patients because of this dysregulation of the autonomic impulse. Although it is difficult to distinguish from the mechanical large bowel obstruction, so we need to have a CT scan or some other or endoscopy to prove that there is no mechanical obstruction. Diagnosis is usually happens with a plain abdomen X-ray or CT scan. It can cause colonic ischemia or perforations, and usually the right side of the colon of the cecum is the place where the perforation happens in the most of the time, and they're associated with a very high mortality. So that is why it is important to identify this kind of syndrome in any patient who's in ICU, and it can lead to compartment syndrome as well. And if the cecal diameter is more than 12 centimeter, that indicates very high risk of perforation. So these patients require a surgery at that point of time. Treatment, neostigemin is the preferred treatment over here because there is no mechanical obstruction. So usually, but we need to remember that we need to give neostigemin only if we rule out a mechanical cause of obstructions. The advantage of neostigemin is that it acts on colon only, and this is a pathology of the colon only. So we can give neostigemin. It's a preferred treatment. Only thing you need to monitor about the bradycardia, heart rate, and everything about the side effect of the neostigemin whenever you are giving neostigemin, IV neostigemin to somebody, and it need to be done under cardiac monitoring. And suppose the obstruction has been relieved, then we can use the polyethylene glycol orally to prevent recurrence. If neostigemin fails or there is some contraindication to give neostigemin, then we can use endoscopic decompression of the colon. But again, we need to remember that there is a very risk of perforation in this with an attempt of endoscopic decompressions. So sometimes it is avoided. When there is any kind of perforation happens, or suppose that there is some imminent perforation is there, or there is a sign of toxic megacolon is there, then surgery is the only choice in these kind of patients. But again, surgery has a very high mortality in this group of patients. So I hope it again clears all these MCQs, all the options of the MCQ clear. Is it done? I think it is done. No? Yeah. Agilvi syndrome. Any questions from Agilvi syndrome? Doctor somebody told that he didn't know about Agilvi syndrome. So I hope you now know about Agilvi syndrome and you can answer.
Yes, sir. Thank you, sir.